Hi, Dr. Aarthy. I was pestering you some questions down there. We were talking about, you were going into the types of hunger that people have, and then you were correlating kind of how you think in terms of what medication to prescribe, Fusimet, Contrave, and things like that. I'm wondering if you can kind of go into that a little bit.
Sure. So the question really sort of originates around, now that we have different options for obesity treatment, anti-obesity medication, how might you think about which option to use for which patient? And I like to start with trying to clarify for the patient, when they say, sort of typical complaint is, I feel hungry all day. I'm hungry all the time. And so I say, okay, well, let's talk about that. Let's try to figure that out, because that's rarely the case, that they feel hungry from the time they wake up to the time they go to bed, despite eating and so forth. So I classify or think about hunger in a few ways. So first is early hunger. That means you and I sit down, we have a meal together, and we eat a reasonable portion. We both agree we're satisfied. And then an hour later, or some period of time that's shorter than what you would normally expect, I feel hungry again, and I could eat the same amount. So it's like my stomach just got empty all of a sudden, and I'm back at it. So early hunger. Then there's hunger where people say, I sat down, ate the meal, but the only way I knew that I was done was I looked at other people and they were done. And then I decided, okay, I should be done. Or I got the, sort of high sign from my wife, like, okay, that's enough. So I have to have an external cue to know that I'm done eating. I don't get that sense of fullness until it's sometimes too late. So I go back and get seconds or thirds, and then by the time I finish that, then I feel like, oh, I'm really stuffed. So I just don't get that satiation. So poor satiation. The third type of hunger is I feel fine with the meal that I've had, but shortly thereafter, or even sometime very soon thereafter, I start thinking about food, and I'm thinking about food all the time. Or the better example is really, someone's brought something tasty into the break room, right? Somebody mentions, oh, there are donuts in the break room. In Winston-Salem, they're Krispy Kreme donuts. And so, you can't concentrate until you go get one of those donuts. Like you are in the middle of doing a really sort of intense email, and you just can't finish that email because you're thinking about the donuts. And then you get one, and then you can sit back down to finish the email, and you keep thinking about the donuts, and then you get up and get another one. And so it just stays on your mind. As long as you know it's there, you're going to eat it. So it's this sort of perseveration around food, in this sort of sense of, if I know it's there, I'm going to eat it. So that's the sort of other type of hunger that people will describe. More recently, I've had people also, you talked about psychiatric issues. People would present with this sort of sense of feeling like they have this feeling that they can't quite get full, but it's different from the poor satiation because it's usually overlaid with some type of anxiety. Mm-hmm. And they will tend to present with this sort of sense of, I just can't quite get full, and I graze all day. I just sort of eat all day. I've got a drawer, the typical history, I've got a drawer at work that I just keep filled with snacks, and I go into it every, hour or so just to kind of keep my nerves from fraying. And so I've now added that to the list of sort of anxiety hunger. And so when you look at those different sort of categories, then we start to think about what happens to, the brain and how those medications work to target certain areas. The last one I'll mention is high hedonic hunger. So some people have a strong hedonic response to food, and they'll say things like, I love to eat. I love cake. It's okay to like a piece of cake, but when you say, I love cake, that's different. And they will tell you they feel a certain way when they get that food. It's usually something that's kind of the right combination for them. Everybody has their combination. It can be salty crunchy, or sweet in chocolate, or but there's this sort of their brain lights up. If we were doing functional MRI while they were even just anticipating getting this food, you'd see areas of the brain that are related to reward, highlighted. And so those things make us think about different treatment strategies, because liraglutide does something different than phentermine does, than the combination of phentermine and topiramate, or topiramate alone, or metformin that Warren mentioned. All of those things do something different, but better understanding the nature of the hunger, or the symptoms, if you will, really makes a difference in terms of how you approach the patient, because sometimes there are also some behavioral things that you can do that really sort of make a difference. Binge eating is another category as well that often is a challenge because there's lack of structure during the day. People go all day without eating, are really vulnerable in terms of mood and mood regulation in the evening, and then come home and binge throughout the night, and then they start the cycle in the morning with morning anorexia. And they say, these are patients who say, I never eat breakfast because I'm not hungry. Well, that's because I didn't finish eating until 11 p.m. last night, and I had a lot of food in that time frame.
One little add-on to that I'm finding quite surprising clinically, and that is now that we are actually using higher plant-based fats, so lots of olive oil, lots of avocado, lots of walnuts, and so on. A lot of my patients that initially start phentermine just to get over the craving, because obviously sugar and starches are addicting, so we're highly, highly addicted. You can try this out with your patients. I always ask them, when you're under stress, what food brings you the most comfort? And it'll either be sweet or savory, and nobody says broccoli. So many times we'll actually have to use phentermine to kind of get them started, and then once they get off, it's a true detox. I mean, they go through 3 or 4 days of getting off sugars, and the starchies, we call it going to Betty Ford, so we call them BF days. And once they do that, and then they add more fat in the diet, that fat gives almost some of the same satisfaction that the phentermine does. And so then some of the patients will actually come off their phentermine a bit, or use it, every 3rd day. But anyway, just another idea on that issue of different patterns of hunger.
Okay. This one kind of fits between Dr. Art and Dr. Figueroa, so whoever might be able to speak to it. But I'm wondering if animal models have been able to replicate or model the metabolic adaptation to weight loss, so you're burning less calories. That's such a Achilles heel. I don't know if either you know that or can speak to that, but...
He said animal model, so that put me second.
Okay, so I'm going to try to do my best to answer that question. In regards to animal models and weight loss, it is very different, and I believe that that's one of the main reasons, things in pharmacotherapies, they don't translate as well when they go to clinical trials. In terms of the feeding behaviors, that's another story, and that's one of the things that we are really interested about. The feeding mechanisms are very similar in humans and rats and rodents. So any drug that can target that particular aspect of behavior has more chances of translating into clinical, efficacy. But in terms of body weight, maintenance, expenditure, and all of that, although there are some resemblances, things that are similar, it's a little bit more difficult to translate,
Totally agree.
Yeah.
I saw some interesting examples of some considerations that need to be made in terms of understanding why some weight loss strategies might not be working and so forth. So I'm wondering, just thinking about the concept of precision medicine, how far advanced would you say we are as far as tailoring treatment plans for the patient, and what challenges would you say we still need to overcome in order to get to a point where we can confidently, or as clinicians, you can confidently tailor or customize treatment plans for your patients?
So I can start. I think this is where we'd all like to go. But if you just think about the things that you heard this afternoon and said, okay, we're going to just package up what we just learned about, childhood experiences and psychiatric medications or other medications that people may be on that cause weight gain or inhibit weight loss, insulin resistance, response to treatment, stress, backgrounds, all of these things, and then add in a basic stuff like age, race, sex, country of origin. If you just said, okay, well, let's just figure out something to tailor based on just that information alone, we'd have, several R01 grants and lots of years of research to do to really kind of validate a model and understand the precision for what we're doing. So I think we definitely need to be going that way. I think there's lots of stuff that we can be looking at. We could just start with the stuff that we already know and then try to, get smarter about that. But I totally think, we should be going that route and trying to get smarter about how to match treatment to the individual patient and then understand that treatment response and evolve the treatment strategy over time to get better, get smarter as we go along.
Yeah, I will just add to that because I'm kind of a shiny object guy. I've spent $500. A company called Biomed said if they evaluated my stool from the microbiome, that they could tell me exactly what I should eat. So you're going to see a lot of these kind of things because we can measure a lot of things now. And so from a commercial standpoint, it's very tempting. And we kind of like the thought of it. But as practitioners, when it comes to precision medicine, the first thing we can do is listen to our patients, period. So when you think one diet fits everybody, we already know we're in a big, big problem. And just as Dr. Aarthy said, there's such a huge variety of who we are and where we came from and so on. So the very first thing we can do in precision medicine is listen to the patient. It's about the patient. It's not about you. I really don't care what you eat. I really don't care what your religion is. I really don't care where you came from, but you should care about where that patient came from and what's going to work best for them. So in my way, that's the best precision medicine right now, is listening to the individual person.
I'm wondering if there are any studies on the drugs that help with weight loss on children and adolescents.
Yeah, so there are a small number of studies that are starting to look at adolescents. I believe liraglutide has a teen study, so adolescents. Orlistat is the only one that I know that's been studied longer term. So that's a lipase inhibitor. But no, we don't really have a large data set, and we don't have much in terms of approved drug options for adolescents, and that's a big gap in our scientific knowledge.
Well, many of them, 1 in 5 has attention deficit, so those would be on stimulants. Stimulants really do inhibit appetite. Sometimes that's the biggest barrier to actually using them, just the fact that they do suppress weight. So you have their two classes, the methylphenidate class and the mixed amphetamine class, and many kids are on those. That's a problem.
So the part of the problem with the stimulants is that they're orphan drugs. So when you can, for $26, you can get a 3-month supply. No drug company is going to be doing a lot of double-blind placebo. And so at the University of Michigan, I just met with them back in Boston, and they actually there have a pediatric obesity center. So what we're doing on this campus is we're actually using their protocols and it is only that. So just as Dr. Ard said, there aren't any for the standard low-cost anti-obesity drugs that poor people can afford. So in the future, there will be new brand names that could be double-blind placebo, which we need. But in the meantime, just using the adolescent approach, that the protocol that's used at the University of Michigan, we're probably seeing 12-year-olds and above, and we have a couple adolescent pediatricians that are referring us patients. And Dr. Ard was helping us today on, we're actually funding and beginning a study on phentermine, and we're working with UCLA to look at the genomics. So how does phentermine works? What does it turn on? What does it turn off? And so at the University of Michigan, ironically, they told me that for the little people, the two-year-olds, 4-year-olds, 6-year-old, they're just using topiramate. And because they're already using topiramate for seizure disorders, so it's no big deal. But just as Dr. Green pointed out, the stimulants are not unusual in a prescribing for, say, like our adolescents. So therefore, but still, so we have all of our parents sign consents, and they know it's off-label. And boy, we see amazing results. These little kids are just doing well, and some of them that have a little attention deficit, their grades go up too. So there you go. But it's just by physician.
For the patient that wants that kickstart to get their weight loss program going, which medication do you recommend? How long do you keep them on the medicines? And if they fail, do you keep them on them indefinitely?
So generally, if someone asks me or uses that phrase kickstart, that's a trigger for me to go into a speech about the chronicity of obesity and the fact that it's a long-term disease. And if we start this medication and find that it's beneficial, then we will likely find benefit for it long-term. It doesn't mean that you have to take it every day, but we know that continuing to use it as a part of a maintenance strategy is beneficial. I've rehearsed that a lot. So usually I go back to what are the issues that we're trying to treat to help me determine which medication I might start. So again, is it early hunger or strong food thoughts or hedonic response to food? If someone says, well, I just feel like I need something to help me in terms of my pace of weight loss, if they've been losing weight at a reasonable pace and they want to go from 1% of their body weight per week, which is very good, to 2% of their body weight per week, that's not an indication for treatment. If they've had difficulty initiating weight loss in the past, then we're going to try to again figure out what are the challenges, and then how do we target the drug to that, so that helping people understand a weight loss medication is not we're not thinking about it the same way we did in the Fen days, which was hey, I could drop 20 pounds by just taking this pill and get to my family, my high school reunion, and be the star. That's not what we're talking about. We're talking about disease remission and control, and we're using these medications or thinking about them in a very different way.
So with that, we're going to actually have to call it to a close, and because we want to make time for everybody to get to the big gala event this evening. And so most of us will stay by, and if you have further questions. But thank you all very, very much for coming, and we hope that you could make the world a better place.